Welcome back to the Deep Dive, the show where we take the densest material, extract the critical insights, and, well, turn them into the knowledge you need, fast.
We're here to give you the context, the why behind the what, and those crucial anchors that make this complex stuff actually stick.
Today, we are strapping in for a deep descent into, one of the most fundamental and utterly transformative tools in modern medicine, gastrointestinal endoscopy.
It's hard to overstate it. Think about it. For centuries, the entire human GI tract was just a mystery, a black box.
Totally inaccessible. You had symptoms and you had inference, and that was about it. But now it's become this navigable highway for both diagnosis and therapy. It's incredible.
And our source material for this deep dive is Chapter 9, Gastrointestinal Endoscopy, pulled directly from, the foundational text, the 28th edition of Baily and Love's textbook of surgery.
Yeah, an essential chapter. And a really crucial note to you listening, especially if you're in medicine, this isn't a recitation. We're not just reading the book to you.
No, absolutely not. This is an interpretation. We're aiming to make this a kind of ready reckoner for your revision.
Exactly. We're structuring it, making it memorable, but we have to stress this should always supplement, not replace reading the actual detailed chapter yourself.
Our mission today is pretty specific, to help you get a really clear, structured, and hopefully memorable understanding of the essential principles, diagnostic, therapeutic, and, critically, the safety principles.
The safety stuff is where people get caught out, isn't it?
It is. It's what requires that instant recall in a clinical setting.
So let's start at the foundation with what you could call the paradox of the GI tract itself. We're talking about this incredibly complex factory, right?
A huge factory. It's doing digestion, absorption. It's a massive hormone producer. It has its own nervous system.
The enteric nervous system, yeah. And it houses the single largest part of our immune system. It's fundamental. And yet, for almost all of human history, its complexity was matched only by the fact that you just couldn't examine it.
Not in real time. Diagnosis was all indirect clues, radiology, palpation, maybe some chemical tests. If something was growing or bleeding on the inside, you had no way of knowing for sure without, major surgery.
Endoscopy just completely changed that equation. It gave us that direct, visual, and eventually interventional link that was missing. Okay, so let's unpack this journey because modern endoscopy feels so integrated now, but it had to overcome two massive and what must have seemed like insurmountable physical barriers.
Two very real barriers, yeah. First, the GI tract is long, and it's tortuous.
It's not a straight pipe.
Not at all. If you tried to push a rigid tube through, you'd cause a perforation. Simple as that. So you needed something flexible, maneuverable, but still robust.
And the second barrier, which is so obvious you almost forget it.
There's no light inside. It's a pitch black tunnel. You have to bring your own light source in and then somehow get an image back out.
So the whole history of this is basically solving the light and the flexibility problems at the same time. The initial idea, using flexible quartz fibers, was actually proposed way back in the late 1920s.
That was the concept. But the engineering breakthrough, the first real historical anchor you need to remember, is Harold Horace Hopkins.
Hopkins, 1954.
Yep. In 1954, Hopkins was the one who successfully built the first flexible fiber imaging device that could actually deliver light down and bring a coherent image back. That was the moment, the shift from darkness to light.
But it took a partnership to get that into a hospital.
It did. Just 4 years later, 1958, you see the birth of the flexible fiber optic gastroscope. And that was a collaboration between Larry Curtis, a physicist who knew the optics, and Basil Hershowitz, a GI trainee who knew what was needed clinically.
That fibroscope was the workhorse for decades. But its days were numbered, really, because of a revolution that happened completely outside of medicine.
The charge-coupled device,
Yeah.
the CCD, invented in the 1960s for other things entirely.
And this is where we really enter the modern era, around 1983, with the first digital electronic endoscope. So why was replacing that bundle of quartz fibers with a tiny camera chip at the tip such a game changer?
Well, the fibers themselves were the limitation. In a fibroscope, you had thousands of these tiny glass fibers. If a few of them broke, you got black spots on your image.
Degrading the view.
Exactly. And the resolution was fundamentally limited by how small you could make those fibers. With a digital scope, the CCD chip at the very tip captures the image electronically, which is then processed by a computer and thrown up on a big high-res screen.
Which means the entire team can see it, not just the person with their eye glued to the eyepiece.
Yeah.
That must have revolutionized teaching.
Oh, massively. Teaching, collaboration, therapeutic precision, and the moment that diagnostic image got better, the therapeutic side just it exploded.
Right.
You look at the timeline in the book, Table 9.1, and you see it clearly. Colonoscopic polypectomy in 69, endoscopic sphincterotomy in 74, controlling GI bleeds by 85. It was a rapid progression from just looking to actually intervening.
Because they could finally see what they were doing with incredible clarity. So let's talk about the state of the art now. The book says we've gone way beyond just simple white light.
We have. We've moved into tissue characterization. We have these modern enhancements like chromendoscopy.
Which is literally using dyes. Right?
Yeah, topical dyes like indigo carmine. You spray it on the mucosa and it highlights all the little surface structures and pit patterns, making abnormal areas just pop out.
And then there's the digital version of that, narrowband imaging, or NBI. How does that work? How does it give us a better view?
NBI is just a brilliant piece of physics. The scope uses filters to only allow two very specific narrow bands of light through. The first is blue light, about 415 nanometers.
Okay.
Hemoglobin just soaks up that blue light, so the tiny superficial capillaries in the mucosa light up in really high contrast. Then there's a green light, around 540 nanometers, that goes a bit deeper and highlights the subepithelial vessels.
So you're not seeing surface color. You're actually visualizing the blood supply that's feeding the tissue.
Precisely.
Mm-hmm.
An abnormal tissue-like dysplasia, or an early cancer, it grows an abnormal, disorganized, dense network of blood vessels. NBI makes those patterns stand out so clearly that sometimes you can predict the histology before you've even taken the biopsy.
And then you've got endoscopic ultrasound, EUS, which adds the dimension of depth.
EUS was another revolution. It put an ultrasound transducer on the end of the scope. So now you're not just seeing the surface mucosa, you can see all 5 layers of the gut wall.
And things outside the gut wall, too.
Exactly. Adjacent lymph nodes, the pancreas.
Mm-hmm.
It completely changed tumor staging.
And the book even mentions things on the horizon, like confocal laser endomicroscopy.
Yeah, that's still a bit more experimental, but the goal there is to get resolution that's comparable to standard histology, to get a microscopic view in real time inside the patient, a so-called optical biopsy.
Wow. Okay, so key takeaway for this first section. Endoscopy evolved from simple fiber optics to these high-def digital scopes, and in doing so, it really bridged the gap that used to exist between, say, a CT scan and a histology slide.
It did. It allows that targeted biopsy, the advanced tissue characterization with things like MBI, and that deep anatomical staging with EUS. It fills that niche perfectly.
All right, let's move on to the practical realities, the endoscopy ecosystem. Because it's not just about the fancy scope, is it? It's about the whole infrastructure.
Not at all. Good endoscopic practice relies on a whole framework. You need a well-designed unit, you need dedicated admin staff, and you absolutely need highly trained nurses who are managing sedation, assisting, and handling decontamination.
And it's all held together by robust clinical governance.
It has to be. Regular appraisal, mandatory assessment of performance. The old see one, do one, teach one model is long gone. Training is a transparent, skills-based process now.
And for anyone studying this, understanding how competency is measured is really key to understanding quality.
It is. You have to record your procedure numbers, of course, but volume on its own means nothing.
Right. You could do 1,000 bad colonoscopies.
Exactly. So we rely on key performance indicators, KPIs, things like your completion rates. The cable intubation rate in colonoscopy is a big one, your complication rates, and crucially, your polyp detection rate.
In the UK, you have bodies like the Joint Advisory Group, JG, that oversee all this.
They do. They use logbooks, direct observations, or DOPS to certify people. It's a very rigorous process.
Okay, let's drill down on that. You mentioned 2 KPIs for colonoscopy, cacal intubation rate and polyp detection rate. Why is the polyp detection rate, the ADR, considered the gold standard for diagnostic quality?
That's a great question. The cacal intubation rate just tells you if you got to the end. It's a measure of technical completion.
Did you finish the journey?
Right. But the ADR, your adenoma detection rate, tells you how good a job you did looking on the way back out. If your intubation rate is high but your ADR is low, it means you're rushing the withdrawal and you're missing things.
And those missed things become interval cancers.
Precisely. A high ADR, which is usually defined as over 25% in men and 15% in women over 50, directly correlates with a lower rate of interval cancers. It is the single best measure of a thorough, high-quality examination.
That makes perfect sense. So talking about the unit itself, what kind of equipment does a modern unit need to have?
Well, it has to match the case mix, but at a minimum, you need your standard forward-viewing gastroscopes, you need some colonoscopes, probably adult and pediatric sizes, and ideally an enteroscope for the small bowel.
You mentioned a lateral viewing scope, but that's less common now.
It is, yeah, mainly for very specific biliary cases,
Hmm.
but the big therapeutic centers, they'll need much more.
Like what?
They'll need capsule endoscopy systems, single or double balloon enteroscopy, and advanced EUS scopes, both the linear and the radial types.
And on the therapeutic side, it's not just snares.
Oh, no. You need a top-quality electrosurgical unit, argon plasma coagulation, or APC, maybe laser units, radiofrequency ablation for treating things like Barrett's esophagus. It's a serious bit of kit.
Okay, now for a critical safety topic that involves everyone in the unit.
Yeah.
Decontamination. These scopes can't be autoclaved, they can't take the heat, so it's all about high-level chemical disinfection.
And it is a strict, mandated two-step process. This is non-negotiable. Step 1 is meticulous manual pre-cleaning.
So physically scrubbing the thing.
Physically scrubbing it,
Yeah.
brushing inside and out, irrigating all the channels. If you don't get the physical debris, the bioburden off first, the chemical sterilant won't work. It can't penetrate.
And then step 2 is the chemical bath.
Right, usually in an automated washing machine using disinfectants like peracetic acid. It neutralizes all the microbiological agents.
What about the risks from the chemicals themselves for the staff?
Staph protection is huge. Things like glutaraldehyde can be sensitizing, so you need proper ventilation and PPE. But there's also a risk to the patient if the rinse cycle isn't perfect and there's residual chemical left on the scope.
Now, the book highlighted a very rare, but a critically important exception to this whole process, prions, like invariant CJD.
This is a key safety anchor for anyone learning. If you perform an invasive procedure, so you breach the mucosa on a patient with known or suspected VCJD, that endoscope must be quarantined and destroyed. Destroyed. There is no currently reliable way to decontaminate a scope from prions. They resist everything. It's an immediate write-off for patient safety. End of story.
That's a sobering thought. And there's also the more common but still dangerous issue with duodenoscopes and transmitting multi-resistant bacteria.
Yeah, that's a big ongoing concern. The duodenoscope has this complex elevator mechanism at the tip for ERCP, and it creates these tiny crevices that are incredibly hard to clean.
A perfect hiding place for bacteria.
A perfect hiding place. And it has been a documented vector for transmitting bugs like Klebsiella or E. coli, even when protocols are followed. It's why duodenoscope decontamination is under constant, intense scrutiny.
Okay, before we move on, let's do a quick check-in question. If you were auditing a new trainee's performance, what specific KPI, other than just the number of procedures they've done, really demonstrates the quality of their diagnostic colonoscopy?
Pause. It has to be the adenoma detection rate. The ADR procedure numbers show experience. Caracal intubation rate shows technical skill, but the ADR is the only one that directly measures how thorough and effective they are at the primary mission of colonoscopy, which is finding and removing precancerous polyps. If you didn't get that, just rewind a minute and listen to that part again.
Let's move into the crucial area of patient care, starting with the legal and ethical shield. Informed consent. I was pretty struck by that statistic in the book. About 1% of medical negligence claims in the U.S. are related to endoscopy.
And a lot of them come back to a failure in the consent process. Informed consent is so much more than just a signature on a form. It's about preserving the patient's autonomy.
And it's your legal defense, really.
It is. The core requirement is that the patient must genuinely understand the procedure, why they're having it, the risks, and what the alternatives are.
So you have to have a very clear discussion about risk. What are the thresholds the book suggests?
The guidelines are pretty pragmatic. You should tell patients about any common minor side effects that have a risk of more than 10%, like a sore throat after an OGD.
Okay.
And critically, you must tell them about any serious but rare events if the incidence is more than 0.5%, so more than 1 in 200.
And what are those main serious risks we need to summarize?
Well, they fall into a few categories. There's damage to dentition, that's a mechanical one, aspiration. Then there are the procedure-specific risks like perforation or hemorrhage, which are obviously much higher for therapeutic procedures like a polypectomy or an ERCP. And then there's the big one, complications from the sedation itself.
Right. So once consent is done, we move to safe sedation. This is where the risk profile really goes up, doesn't it?
It does. It's a real tightrope walk. You're trying to avoid medication-induced respiratory depression, especially in elderly patients or those with heart or lung problems. The book is very clear. This is the single greatest preventable cause of death related to endoscopy.
So let's get into the details of the protocol.
Yeah.
We often use opiates like fentanyl and benzodiazepines like midazolam together, but they have this synergistic effect.
Yeah, synergistic is a word. 1 + 1 = 3 in terms of the depression risk. So To manage that, the protocol is to give the opiate first for the pain relief, and then you have to reduce the dose of the benzodiazepine.
And you have to remember the timing, right? The benzo doesn't have its max effect straight away.
That is so important to remember. The peak effect is delayed. It can be 9 to 20 minutes after you've given the IV dose. So if you push a big dose too quickly, you risk over-sedating the patient 15 minutes later when that peak finally hits. Slow titration is the key.
And monitoring is non-negotiable.
Absolutely. Supplementary oxygen for all sedated patients. Pulse oximetry is mandatory. For high-risk patients, you need blood pressure and ECG monitoring as well, and you must have a trained assistant whose only job is to monitor the patient. They're not there to help the endoscopist.
And that leads to the critical post-procedure warning, which I think can sometimes be forgotten.
The long half-life of the benzodiazepines, it can be anywhere from 4 to 24 hours. The patient might feel fine, but their judgment is impaired.
So they absolutely cannot drive.
Cannot drive, cannot drink alcohol, cannot operate machinery, can't sign legal documents. For a full 24 hours, it has to be drilled into them and their escort.
Okay, let's anchor this with a case study. Let's say we have Mr. Smith. He's 82, he's anxious, and he needs a complex therapeutic procedure, maybe a large EMR. He also has severe COPD. Why is he at such a high risk, and what's the critical step the team needs to take?
Okay, that's a classic high-risk scenario. His risk is sky high for a few reasons. 1, his age means he'll clear the drugs much more slowly. 2, it's a long, complex procedure, so he'll need more sedation. And 3, the absolute critical one is his COPD.
His respiratory reserve is already shot.
It's minimal, so any medication-induced respiratory depression could easily tip him into respiratory arrest.
So what's the critical step for the unit?
You have to escalate. This is not a routine sedation case. This requires the involvement of an anesthetist or a specialist sedation team right from the planning stage. Doses will be tiny and carefully titrated, and you must have reversal agents in naloxone and flumazenol drawn up and ready in the room.
And you'd have airway equipment ready to go, I assume.
You'd treat it as a general anesthetic, essentially. You have to be prepared to manage his airway at a moment's notice. That's how you make it safe.
Okay, let's shift to other complex patient groups that need proactive management. Diabetes. It affects about 2% of the population, so this is a daily issue in any endoscopy unit.
It is, and this is mainly about logistics. The priority rule you have to remember is diabetic patients should be endoscoped first on the morning list.
To minimize their fasting time.
Exactly. That's the biggest disruptor to their glycemic control. And the specific plan will depend on whether they're type 1 or type 2, how well controlled they are, and what procedure they're having.
A brittle type 1 having a colonoscopy prep is a whole different ballgame to a stable type 2 having a quick OGD.
Completely different. The complex cases, they often need to be admitted for management, with the diabetes team involved to manage their insulin.
Okay, next up. Antibiotic prophylaxis. The default rule is clear. It is not needed for most routine diagnostic scopes. So when do we need it?
We give it for a few specific reasons. To prevent bacterial endocarditis in high-risk patients, like those with prosthetic heart valves. To prevent infection of other prostheses, like a new hip joint. Or to prevent sepsis in someone who is severely immunocompromised.
So it's a balance between the risk of the procedure causing bacteremia
Yeah.
and the patient's underlying risk.
That's it. And some procedures have a much higher risk of causing bacteremia. Esophageal dilatation is a big one. The rates are really high, something like 34 to 54%.
Because you're stretching and causing microtears in the lining?
Exactly. Sclerotherapy for varices is also high risk. And PEG insertion is another classic example where prophylaxis is mandatory.
Why for PEG?
Because randomized trials have shown it significantly reduces the risk of infection at the stoma site on the skin. You're creating a track from a contaminated organ, the stomach, to the outside world.
Right. And what about in the biliary system with ERCP?
For ERCP, you give routine antibiotics anytime you're manipulating an obstructed biliary tree, especially if you're not sure you can achieve complete drainage. Biliary sepsis is a killer. And you'd also give it if you're doing an EUS-guided aspiration of a pancreatic cyst.
Okay, this brings us to what is probably the most complex area of pre-procedure management, anticoagulation. This is a real balancing act.
It's the ultimate tightrope walk, isn't it? You're managing warfarin, DOACs, antiplatelets. You're trying to prevent a bleed during the procedure, but without causing a catastrophic clot like a stroke or a PE by stopping the medication.
Let's start with the emergency scenario. A patient comes in with an active GI bleed and they're on warfarin.
Okay, so the priority there is to correct their clotting just enough to let you do the endoscopy safely. You don't want to fully reverse them because that has its own risks. The target is usually an INR of about 1.5. That's generally enough to allow for endoscopic therapy.
And for elective procedures, it's all about risk stratification, low risk versus high risk procedures.
Yes. Low-risk procedures would be your diagnostic scopes, simple biopsies. For those, the book says that standard doses of aspirin or NSAIDs generally don't need to be stopped.
And the high risk category.
That's anything involving cutting or heat. So a large polypectomy, an ERCP with sphincterotomy, EMR, ESD, stenting, all of those require very careful management.
So let's focus on that crucial management anchor. The warfarin strategy for a patient with a high-risk condition, like a mechanical mitral valve. They need bridging therapy. Can you walk us through the timing?
This is high-yield stuff, absolutely. Warfarin has a long half-life, so you have to stop it 5 days before the procedure to allow the INR to fall.
But you can't leave that patient unprotected for 5 days.
You can't. The risk of their valve clotting is too high. So you bridge that gap with low molecular weight heparin, LMWH.
And that's ideal because it's short-acting.
Exactly. It's predictable and short-acting. So you stop the warfarin, then 2 days later, you start the LMWH. You omit the dose of LMWH on the morning of the procedure itself.
So its effect is minimal by the time you're doing the high-risk bit.
Precisely. Then you restart the warfarin that evening, and you continue the LMWH daily until the INR is back up in the therapeutic range, which usually takes another 3 to 5 days. It's a very logical, timed process.
And what about the newer drugs, the DOACs?
The DOACs are simpler because they have much shorter half-lives. They don't generally need bridging. The key thing with them is to know the specific drug and the patient's renal function, because poor kidney function can dramatically prolong their effect. But typically, you'd stop them for a few days before a high-risk procedure and restart a couple of days after.
All right, let's move on to the actual procedures, starting with the most common one. Upper GI endoscopy, or OGD. This looks at the esophagus, stomach, and the first part of the duodenum.
It does. And a key technical point is that it's very easy to miss pathology in the gastric fundus and cardia, right up by where the scope enters.
Which is where the retroversion technique comes in. That's a key anchor, isn't it?
It is absolutely essential. Retroversion is where you turn the tip of the scope a full 180 degrees to look back at itself inside the stomach. It's the only way to get a proper, complete view of the cardia and fundus. It's a mandatory part of a complete examination.
And once you're in there, OGD is great for sampling.
Yeah, you can take mucosal biopsies for histology. You can do rapid urese tests for H. pylori right there in the room. You can take brushings for cytology, aspirates for microbiology. Very versatile.
Okay, let's talk indications. This is a key question for any student. When is an OGD the right test to do?
Well, it's appropriate if a patient's symptoms are persisting despite medical therapy or, and this is the crucial part, if their symptoms come with any warning signs.
Red flags.
Red flags. So that's dysphagia, difficulty swallowing, any sign of bleeding, anemia, unexplained weight loss, or intractable vomiting, any of those, and you need to have a look.
The book cautions quite strongly against the overuse of OGD, especially with open access systems.
It does. It has led to a lot of unnecessary scopes in young patients who just have simple dyspepsia or reflux with no red flags. The risk and the cost just don't justify it.
So the guidelines say to try empirical acid suppression first.
Exactly. Try acid suppression, do a non-invasive H. pylori test. Only if that fails, or if red flags develop, should you reach for the scope.
Now, shifting to therapeutic OGD. Let's start with emergency hemorrhage control. Things have changed a lot here.
They have. For bleeding esophageal varices, the standard of care has completely shifted. Endoscopic band ligation has replaced injection sclerotherapy.
Why?
It's just better, it's safer, it's more effective at stopping the bleeding, and it has a much lower complication rate, especially a lower risk of causing strictures later on.
And what about for a bleeding peptic ulcer, one that's actively spurting?
The standard there is dual therapy. You do two things. First, you inject dilute adrenaline or epinephrine to cause some local vasoconstriction.
To slow it down.
Right. And then you immediately follow that with a second technique, which could be thermal coagulation, a heat probe, or applying endoclips. Adrenaline on its own is not enough, and these patients must get 72 hours of IV proton pump inhibitors afterwards.
And for those slower chronic bleeds, like from angiectasia,
For those, argon plasma coagulation, or APC, is often the safest bet. It's a non-contact method that uses ionized gas to deliver thermal energy. The key advantage is that it gives a very controlled, superficial depth of burn, which minimizes the risk of perforation, especially in thin-walled parts of the gut.
Okay, moving to elective non-bleeding therapeutics. strictures?
Benign strictures are usually managed with dilation. You can use through-the-scope balloon dilators, which are probably the most common method now, or the older Savary-Gilliard bougies, which run over a guide wire.
And for achalasia, the failure of the lower esophageal sphincter to relax.
Two main endoscopic treatments. The primary one is pneumatic balloon dilation, using a very large 30-40 millimeter balloon to forcibly tear the muscle fibers. The other, more advanced option is a peroral endoscopic myotomy, or POEM.
Which is basically surgery through the mouth.
That's a good way to think of it. You tunnel under the mucosa and cut the muscle endoscopically. Very effective, but highly specialized.
What about Botox injections?
It's an option, but the benefit is very temporary, usually only 3 to 6 months. So it's really just for frail patients who aren't candidates for anything else.
We also have to mention PEG insertion, percutaneous endoscopic gastrostomy.
A vital procedure. It provides long-term feeding access for patients who can't swallow safely, for instance, after a stroke, or with motor neuron disease or head and neck cancers. It's proven to improve nutritional outcomes.
And for palliating malignant obstruction, like in esophageal cancer.
That's a classic role for a self-expanding metal stent, or SEMS. You deploy it across the tumor and it expands, opening up the lumen and providing rapid relief of their dysphagia. A huge quality of life improver.
And finally, let's just touch on those advanced resection techniques again, EMR and ESD.
These have been game changers. Endoscopic mucosal resection and endoscopic submucosal dissection. They allow us to remove early superficial cancers like high-grade dysplasia in Barrett's or early gastric cancer that would previously have needed a major operation.
So what about this safety profile? What are the main OGD complications?
A diagnostic OGD is incredibly safe. The serious complication rate is about 1 in 10,000. Most of the risks are related to the sedation or the patient's comorbidities. The rest goes up dramatically with therapeutic procedures.
And the big one is perforation. If you suspect it, what's the management sequence?
Early diagnosis is absolutely key. The patient will have sudden severe pain, tachycardia. You have to act fast. Make them nil by mouth. Start YV fluids and broad-spectrum antibiotics immediately.
And then you need imaging to confirm.
Yes, a CT scan or a water-soluble contrast study to see where the hole is and how big it is. And you must get an urgent surgical review. A surgeon needs to see that patient straight away because many of these will require an operation.
Right. For a long time, the small bowel, all 6 or 7 meters of it, was basically the final frontier of the GI tract. It was just inaccessible.
It was a huge diagnostic blind spot. If the OGD and the colonoscopy were normal, you were left with pretty low-yield tests like barium follow-throughs. You could see anatomy, but you couldn't see the mucosa or take a biopsy.
So what are the main reasons we'd need to assess the small bowel today?
The single most common reason is to investigate obscure GI blood loss. That's bleeding that's continuing after you had a negative OGD and colonoscopy.
It could be hidden, occult bleeding causing anemia, or obvious bleeding.
Exactly. Other reasons would be to look for causes of malabsorption, maybe find hidden Crohn's disease, or for surveillance in patients with polyposis syndromes.
The book highlights 2 massive advances that opened up this territory. Let's start with the diagnostic one, capsule endoscopy, the camera pill.
The camera pill is a triumph of non-invasive tech. It gives you diagnostic views of the entire small bowel with minimal discomfort in a patient who isn't sedated.
And it just travels through with peristalsis.
It does. It's a little capsule with a camera, LEDs, a battery, and a transmitter. It takes thousands of pictures and sends them to a recorder the patient wears on a belt.
It sounds perfect. But there is one major safety anchor here. What is the absolute contraindication?
It is absolutely contraindicated in any patient where you know or even suspect they have a small bowel stricture.
Because it'll get stuck.
It'll get stuck. It will cause a bowel obstruction, and the patient will need an operation to have it removed, which completely defeats the point of a non-invasive test.
So if you do suspect a stricture, what's the safety protocol?
You must use a dummy patency capsule first. It's the same size, but it's made of a material that will dissolve after about 40 hours if it gets impacted. You track it, and if it passes through safely, then you know it's safe to give the real camera pill. No patency, no pill.
Okay, now for the therapeutic revolution.
Yeah.
Single and double balloon enteroscopy. You called it the slinky technique.
It's the best analogy. This is the technique that gives you endoscopic access for biopsy and therapy to the entire small bowel. You can go in from the mouth or from the rectum.
So how does the slinky part work?
The scope itself has a balloon, and it runs inside an overtube, which also has a balloon. You advance the scope, inflate its balloon to anchor it, then you slide the overtube down over the scope.
I see.
Then you inflate the overtube balloon, deflate the scope balloon, and advance the scope further. By doing this over and over, you're pleating or accordioning the small bowel onto the overtube.
Stacking it up to get deeper and deeper.
Exactly. It allows you to reach that previously inaccessible midgut and actually do things.
So you can do biopsies, polypectomies, APC.
A full range of therapeutics. You can treat what the capsule found.
So the key takeaway here is pretty clear. Capsule endoscopy is for diagnosis. Balloon enteroscopy is for therapy.
That's the simplest way to remember it. Capsule to look, balloon to treat.
Next up is ERCP. And this is a procedure whose role has shifted dramatically, hasn't it? From being mainly diagnostic to now being almost exclusively therapeutic.
It's a classic example of technology changing practice. ERCP used to be the only way to see the biliary tree. But then magnetic resonance cholangiopancreatography, MRCP, came along.
Non-invasive MRI scan.
A non-invasive, very safe MRI scan that gives you beautiful pictures of the bile ducts. And because ERCP has a significant unavoidable complication risk, it just doesn't make sense to do a risky procedure just to get a picture anymore.
So now it's only used when you actually need to intervene, and it requires a special scope.
It does. A side-viewing duodenoscope. This is crucial. It looks out of the side, not the front. This lets you line up perfectly with the papilla of Vater in the duodenum, which is the opening to the bile duct.
I mean, you cannulate it.
You cannulate it, usually over a guide wire, and inject contrast under X-ray guidance, under fluoroscopy, to see the ducts.
So if the MRCP finds a stone or a stricture, the ERCP becomes, as you say, the plumber of the biliary system.
That's its job now. The main indications are relieving biliary obstruction, so removing gallstones from the common bile duct, or managing strictures, both benign and malignant.
When you're retrieving a gallstone, what's a mandatory first step?
You have to perform an adequate biliary sphincterotomy. You have to widen the opening. You use a special catheter with a wire to make an electrical cut in the sphincter of Oddi.
And once the opening is bigger?
You can get the stones out with balloons or wire baskets. If a stone is too big, you can use a mechanical lithotripter to crush it first.
And what about for strictures?
For benign strictures, you'll do a balloon dilation and often put in temporary plastic stents to keep it open. For malignant strictures, from something like pancreatic cancer, you'd usually place a permanent self-expanding metal stent to palliate their jaundice.
Now, let's talk about the high-risk nature of ERCP. The book makes it clear this is one of the most dangerous endoscopic procedures.
It is. The patients are often sicker to begin with, they need deep sedation, and you're working in a very delicate area. The overall mortality rate is close to 1%.
So what are the specific must-know complications?
Well, there are mechanical risks like duodenal perforation or bleeding after the sphincterotomy, but the most common and potentially the most severe complication is post-ERCP pancreatitis, or PB.
PP. It happens in about 4.3% of cases. What are the risk factors for developing it?
It's more common in younger patients, anyone who's had PP before, and in cases where the procedure was technically difficult, so difficult cannulation, or accidentally injecting the pancreatic duct.
Okay, and what is the single most important evidence-based intervention to prevent PP? This is a vital anchor point.
This is a high-yield fact. Patients should receive a parectal suppository of a non-steroidal anti-inflammatory drug, NSAID, specifically indomedacin or diclofenac, either just before or just after the procedure.
Assuming no contraindications.
Assuming no contraindications, of course. It's thought to dampen the inflammatory cascade that's triggered by manipulating the papilla, and it significantly reduces the rate of pancreatitis. It's standard of care.
Okay, let's turn our attention to the other end of the GI tract, colonoscopy, the absolute cornerstone of colorectal cancer screening.
And the goal is twofold. One, find early-stage cancers, and two, find and remove the adenomatous polyps before they can ever become malignant.
Which brings us right back to quality metrics and the adenoma detection rate, the ADR.
It does. A high ADR is directly linked to a lower rate of interval cancers. It is the quality marker that matters most.
So how do you improve your ADR?
It's all about being meticulous, ensuring the patient has excellent bowel prep. Taking your time on withdrawal, a minimum of 6 minutes is often the target, changing the patient's position to open up blind spots, and doing a second look in the right colon.
Now let's talk technique. The biggest challenge is getting the scope to the end, to the cecum.
The target is a caecal intubation rate over 90%, and you have to prove you're there by identifying the landmarks. the appendiceal orifice, the ileocecal valve, or by actually intubating the terminal ileum.
The key technical anchor here for trainees is loop resolution. What happens if you just keep pushing?
You create a loop, the scope bows inside the patient, usually in the sigmoid colon. And when that happens, pushing more on your end just makes the loop bigger, it causes pain, and the tip of the scope doesn't advance.
Paradoxical movement.
Exactly. The key is to recognize it, pull back, apply torque to straighten the colon, and then advance the straight scope. That's the art of it.
And for insufflation, for blowing up the colon to see.
Carbon dioxide, CO2, is much preferred over air. It gets absorbed by the body much, much faster.
So less bloating and pain for the patient afterwards.
Way less. It makes a huge difference to their tolerance of the procedure.
Okay, let's talk about advanced imaging again, but in the colon. The goal is to characterize polyps before you take them out.
Right. We can use dye-based chromendoscopy with indigo carmine to highlight the pit patterns on the surface of a polyp. This is really useful in IBD surveillance to spot flat dysplasia.
And NBI, narrowband imaging again.
Same principle as in the stomach. The blue and green light highlights the vascular patterns on and just below the surface. We use classifications, like the NICE classification, to predict in real time if a polyp is a simple hyperplastic one or a more worrying adenoma, which helps guide how you resect it.
So let's talk about that. Therapeutic colonoscopy, polyp resection. How do you choose the right tool?
It depends on the size and shape of the polyp. For small, flat polyps, up to about 15 millimeters, we now use a cold snare. It just cuts the polyp off without any electricity.
Which is safer?
Much safer, lower risk of a deep thermal burn. For polyps on a stalk, a pedunculated polyp, you'd use a hot snare, which uses diathermy to cut and coagulate the blood vessel in the stalk at the same time.
And for the big, flat sessile polyps, that's where EMR and ESD come in.
It is. Endoscopic mucosal resection, EMR, is the workhorse here. And the critical anchor for EMR is the submucosal injection. You inject a solution, like saline with a blue dye, underneath the polyp.
To lift it up.
To lift it up and create this protective cushion, this wheel, that lifts the polyp away from the deep muscle layer, the muscularis propria.
Which protects against the main risk of perforation when you use the diathermy snare.
Precisely. It allows you to safely shave the polyp off the top of that cushion. And then ESD, endoscopic submucosal dissection, is the next level up for very large or suspicious lesions where you meticulously dissect it out in one piece.
Okay, let's quickly review the complications. Perforation and hemorrhage are the big ones with polypectomy.
They are. The risk is around 0.1% for perforation and 0.3% for hemorrhage. And the hemorrhage can be delayed. It can happen up to 2 weeks later.
And what about post-polypectomy syndrome? This sounds like a tricky diagnosis.
It is. The patient develops abdominal pain and fever, signs of localized peritonitis. But it's not a frank perforation. It's thought to be a transmural burn, where the heat injury has gone all the way through the wall, causing inflammation, but without an actual hole.
So how do you tell the difference between that, which you can manage conservatively, and a true perforation, which needs surgery?
The key is a CT scan, a CT of the abdomen. If you see free air outside the bowel, that's a perforation, and they need a surgeon urgently. If you just see localized inflammation and thickening of the bowel wall with no free air, it's likely post-polypectomy syndrome, which can be managed with antibiotics and observation. But either way, a colorectal surgeon needs to be involved early.
All right, our last section, endoscopic ultrasound, EUS. We touched on it earlier, but it really deserves its own focus because it solves the single biggest limitation of normal endoscopy.
Which is that you can only see the surface. EUS combines the endoscope with a high-frequency ultrasound probe at the tip. So you get the mucosal view, and you also get a detailed ultrasound image showing you all the layers of the gut wall and the structures next to it.
It's what allowed for accurate local staging of tumors.
Completely. It revolutionized T-staging for esophageal, gastric, and rectal cancer.
The book talks about two main types of echoendoscopes, and understanding the difference is a high-yield point.
It is, because their form dictates their function. First, you have the radial echoendoscope. It has a probe that gives you a 360-degree circumferential ultrasound image.
Like a cross-section.
Exactly. It's a diagnostic tool. It's perfect for staging a tumor, seeing how deep it's invading into the wall layers. The T stage.
And the other type is built for intervention.
That's the linear echoendoscope. It's a side-viewing scope, and its ultrasound probe is arranged in a line parallel to the scope. This creates an image plane that your needle will pass through.
So you can see your needle in real time as you do a biopsy.
Precisely. It's designed for ultrasound-guided sampling and therapy.
So what are the main indications for using EUS?
Well, diagnosis and staging, as we said, T and N staging of GI and pancreatobiliary cancers. It's also great for looking for tiny gallstones, microlithiasis that a normal ultrasound might miss.
And therapeutically, the linear scope is the workhorse.
It is. EUS-guided fine needle aspiration, or FNA, is the main use. You can biopsy suspicious lymph nodes, pancreatic masses, submucosal lumps, and you can also use it for drainage procedures, like draining a pancreatic pseudocyst into the stomach.
Okay, let's do one final check-in question to really lock in that difference.
Mhm.
A patient has a lump under their stomach lining, a submucosal lesion. You need to know how deep it is, and you need a tissue diagnosis. Which EUS probe is best for the staging, and which one is for the biopsy?
Pause. The radial probe is best for staging the depth because it gives you that beautiful 360-degree anatomical view of the wall layers. But to get the tissue sample, you need the linear probe because it's the only one that allows for accurate, real-time, ultrasound-guided FNA. If that distinction isn't crystal clear, please rewind and listen to that part again. It's a fundamental concept.
What an incredible journey, from the early days of just trying to get a flickering image out of the stomach to today, where we're doing what is essentially microsurgery through a flexible tube.
We've covered a huge amount: the history, the governance, the patient safety protocols, and these amazing therapeutic capabilities. Endoscopy is it's completely integral to how we manage GI disease now.
And it seems like even with advances in radiology like CT and MRCP, the unique ability of the endoscope to take a biopsy and to perform therapy means its future is secure.
Absolutely. The diagnostic role might shift a bit, but the therapeutic role is only going to expand. We're seeing it with new technologies like AI being developed to help spot polyps, to augment that adenoma detection rate.
That's fascinating.
It is. But as these procedures get more and more complex, ESD, US-guided therapies, and our patients get older and have more comorbidities, competent practice isn't just about hand-eye coordination anymore.
It's about the whole system.
It's about rigorous governance, meticulous consent, and rock-solid safe sedation protocols. That's the safety net that protects every single patient.
So let's end with a final provocative thought for you to take away: the historical lines between medicine, radiology, and surgery. They're getting really blurry because of therapeutic endoscopy.
They really are. I mean, you take a procedure like POEM, the peroral endoscopic myotomy. That's a surgical myotomy. It's just being done through a natural orifice with an endoscope instead of a scalpel.
So the question for the next generation of doctors is this: where does the endoscopist end and the surgeon begin?
It's a real convergence of skills. You need the anatomical knowledge of a surgeon, the technical skill of an endoscopist, and the medical insight of a physician, all in one person.
A fascinating place for medicine to be heading. For those of you studying, please go back to Chapter 9 of Baily and Love and use this as your guide to dig into the details.
Use this as the map, but go and explore the territory in the book for yourself.
Thank you for diving deep with us.
Until next time.